All right. I'm John Craig, Division Chief of Rhinology. I'm going to talk today about sinusitis and rhinitis, and while I've geared the lecture toward residents, it's really generalizable to the clinical practices of all primary care providers. I have no financial disclosures. Here's our general outline for today. We're going to start off with a very brief anatomy crash course, just get you oriented to the sinuses. We will deconstruct what we think of as rhinosinusitis and then define it based on criteria. We'll talk about how to manage these patients and when you should refer them to ENT, or maybe there's someone else that you should be referring these patients to. I want to talk just a little bit about unilateral sinus disease. Not everyone's thinking about this, but it's actually pretty important because there are some concerning conditions. And then what is not sinusitis? We'll spend a little extra time on this because the overwhelming majority of what we see day in, day out that patients describe as, quote, sinus actually is not sinusitis. And then we'll end on a fun little section on rhinitis. All right, so here's our anatomy crash course. So the sinuses, as everyone's familiar with, are air-filled cavities in the face and skull with defined bony boundaries. And you can see here the red outline just shows the ethmoid cavity. The middle turbinate is their medial, the medial orbital wall is lateral, and the skull base is superior. And this is just one of the sinuses, but all of them have these defined boundaries that we speak of. These boundaries and all the little partitions between the boundaries are lined by ciliated respiratory epithelium that has a mucus layer on top of it with colonizing bacteria, and then inflammation develops submucosally. And this is where all the different inflammatory reactions ensue. You get the edema of leaky capillary vessels and then the swelling that ensues thereafter. All right, so from the lining of the sinus cavities, the mucus is secreted and then it drains into the nasal cavity based on mucociliary clearance. So that pseudostratified respiratory epithelium has cilia that beats the mucus toward the nasal cavity, and it can drain through the middle meatus, where the majority of the sinuses drain, maxillary, anterior ethmoid, and frontal. Or you can have the sphenoethmoid recess more posteriorly in the nose, which you guys really don't have to know about, I realize, but just know that each sinus has its own drainage pathway, basically. All right. When we do sinus surgery, it's modeled by this gray that I just put there in the ethmoid cavity. Basically, we remove all the little bones in between the bony boundaries to create wide openings so we can deliver topical therapies to those boundaries. And there is your crash course in anatomy and how surgery plays into it. All right, so let's talk about sinusitis. First, some acronyms that are going to show up throughout this talk. So acute rhinosinusitis, or ARS, this is less than 1 month of symptoms. I'm going to say this multiple times throughout the talk to hit home with it. Recurrent acute sinusitis, or RARS, this is when you just have multiple episodes of acute rhinosinusitis with normal periods in between. Whereas chronic rhinosinusitis is 3 months or more of symptoms. SNOT-22, yes, it's one of the best acronyms for a quality of life index that we use. It's pretty popular. Part of it probably is from the acronym itself, but it is pretty powerful. We use this, if you ever look at my notes or some other rhinologist notes, frequently they'll use this. 22 items there, 0 to 5, so higher scores, more detriment to their quality of life, and we use this to track treatment outcomes. Okay, we don't really use the absolute score as much, but if you see a significant decrease in about 10 points or more after treatment, that's been shown to be clinically meaningful. Okay, so rhinosinusitis, it is a syndrome. It's inflammation and or infection of the sinonasal mucosa that causes symptoms. It's a symptomatic syndrome. That's how we define it. If it's not causing symptoms, we don't actually really think of rhinosinusitis as a pathologic condition. That gets a little murky sometimes, but that's the general consensus. All right, and if you go by either United States or European guidelines, it seems that we have worldwide agreement that you need 2 or more symptoms of the following: anterior drainage out the front of the nose, posterior drainage down the throat, nasal obstruction as in decreased airflow through either side, smell loss, or cheek or forehead pressure. Okay, so I highlight this because it's only 5 symptoms. And then, yes, it's still kind of annoying to ask about 5 symptoms with every patient on top of everything else you're asking them, but you don't need to remember like 11 or 12. I've seen some providers ask about major and minor criteria. Those are older. We don't talk about them as much anymore. You just need to remember these 5. And then again, acute is less than 1 month, whereas recurrent is recurrent discrete episodes of less than 1 month. Chronic is more than 3 months. And so you might be wondering, what about in between? So there is this entity, it's kind of nebulous, it's talked about in the literature as subacute. The thing is, there's no data really to show that treatment outcomes are any different for these patients. And so what you really have to do is tease out, do you think it's more likely acute or more likely chronic? Okay. I know just anecdotally, what's interesting is that I rarely see patients with symptoms between 1 and 3 months. It just usually they fit into the other two categories. So that's probably why it hasn't been studied as much. All right, now I hit this point home because it's so important. You have to get a history for each of these 5 symptoms, which is kind of frustrating. I see it all the time, and I'm not just blaming residents because attendings do it too. They just ask, all or none. Do you have anterior drainage, posterior drainage, blah, blah, blah. And that feels like you're taking a complete history. But what if they don't occur together and they're totally separate reasons? So it's really important to take a full history for each. This I will hit on multiple times in this talk. Least reliable symptom of those 5 cardinal symptoms, facial pressure. It's counterintuitive because everybody comes up through med school thinking facial pressure, sinusitis. It's actually an uncommon cause overall. And by the way, feel free to ask as many questions as you want, but it's best if we get through the whole talk because I got about 45 solid minutes here. All right, so then those are the symptomatic or subjective criteria for rhinosinusitis. You also have to have objective criteria, and that's going to come in the form of endoscopic findings or CT findings. Endoscopic findings, we look in the nose, in the middle meatus, and look for edema, pus, or polyps, signs of inflammation or infection. CT findings that can be consistent with sinusitis, mucosal thickening, or opacification. So I pose this question, it's more just food for thought, but which do you think is more common, recurrent acute sinusitis or chronic rhinosinusitis? Take a few seconds. So it's interesting. I don't know. I know coming up through training, I might have thought the opposite, but now having seen all these patients, I know better. But it's clear that chronic rhinosinusitis is more common than recurrent. And multiple guidelines have supported this. And we talk about with versus without polyps in the chronic sinusitis setting. So without polyps tends to be more common, 15% of the population, 15% prevalence rate in the United States at least. With polyps, 4%, and then recurrent acute is less than 1% of all rhinosinusitis cases. And so I think it's helpful to ponder that when you see these patients that present with recurrent facial pressure in your office, and often just an isolated facial pressure. And so think about, if you're seeing more than 1%, if you're diagnosing more than 1% of your patients with sinusitis in that setting, you might be overdiagnosing. Actually, pretty certainly. Okay, next question I pose to you. Somebody comes in and says, "Doctor, I have a sinus infection." What is the most important symptom you ask that patient to gauge how likely you think they have sinusitis? Okay, now this is anecdotal and it's not been proven per se, but just talking amongst peers, seeing patients day in, day out, correlating with their scopes, anterior drainage is by far the most likely for sinusitis. So that means they're blowing their nose, they're getting thick, nasty mucus out at some point. I'm not saying they're always going to have it, but of all those other symptoms, that's the one that I really bank on. Somebody tells me they have postnasal drainage, it's so bad, facial pressure's out of control, and then I say, "Oh, so you blow out nasty mucus," and they say no, well, then I kind of raise my eyebrows and I take a really close look with a scope and see if they actually have it. So here's my pearl on this point. When patients come in, they tell you all kinds of different symptoms, right? I've got sinus, I got pain. You have to really ask them specific questions. They often will say, "I got congestion and drainage." You have to ask what they mean by this. So for congestion, you have to ask them, do you mean nasal obstruction or facial pressure? It feels like it's 50-50 to me. I've even had my residents kind of just anecdotally think about it. They agree. Most people, when they say congestion, you don't know what they mean. All right, now drainage, you have to break it down whether it's thick, colored, or thin and clear. If you read these guidelines, there are some older studies saying that color does not predict whether it's a bacterial infection. I will tell you, when I see patients with green that report green drainage, there's a higher likelihood of there being an infection. Not a perfect correlation or anything, but again, I think that thickness and thin is probably a better determinant. Thin and clear drainage is just different from typical sinusitis. All right, so to summarize this pearl, Thick mucus and nasal obstruction are more likely sinusitis. Prominent facial pain and thin clear drainage, less likely sinusitis. Take a snapshot of that. It's actually pretty helpful. All right. The other problem, of course, symptoms alone don't make the diagnosis. So here's the next pearl. Diagnosing rhinosinusitis, acute or chronic, requires nasal endoscopy, not necessarily a CT scan, which I acknowledge is problematic for primary care providers. So, what is nasal endoscopy and why do I make a claim so adamantly? You can either have rigid nasal endoscopy, which is the picture on the left, or flexible endoscopy on the right. And what we're doing is we're assessing for nasal patency to assess that nasal obstruction, septum, turbinates, polyps, tumors. And then we're looking deeper in the nose, and we're assessing for inflammation or infection in sinus drainage pathways that we mentioned earlier. Biggest bang for the buck. So, by the way, that's where we put the scope between the turbinates and the septum, looking into that zoomed-in area, which is the middle meatus. That's where most of the sinuses drain, so that's an indirect correlate of sinusitis. Very good predictive values if you see mucus, pus, or swelling of some sort there. We also look in the sphenoethmoid recess for the sphenoid disease. And then we look all the way back to the nasopharynx, because a lot of patients will say they have postnasal drip. You really want to see, okay, do they frankly have postnasal drip? Because that's where it would be. Again, trying to correlate symptoms with the endoscopy. So here would be endoscopy findings on the right nasal, in the right nasal cavity. This is a normal scope. We're looking directly at a middle turbinate there. To the left of the screen is lateral, and that's the middle meatus. So no pus, no edema, nothing. Whereas this patient, you see kind of a multilobulated middle turbinate, pus in the middle meatus, a lot of swelling. That would be positive for rhinosinusitis. Again, an indirect correlate of what's going on inside the sinuses. And then finally here we have polyps. These are kind of multilobulated, crazy, great-looking pieces of swelling filling the nose here. These patients are going to have a tough time breathing and smelling. All right, so those are endoscopy findings. Why do I kind of hate on CT scans, and why should we view them with caution? Here's a great example. Saw this patient, now it's been a few months, but came in just miserable, referred from her primary care provider, SNOT 22 score of 78 out of 110, which is really high, and just the worst bilateral cheek and forehead pressure, which she described as sinus pain. And somebody got a CT scan. Okay, and here's the trouble. So here we see, I can't point on this, but bilateral ethmoid partial opacification, left maxillary sinus mucosal thickening, read by the radiologist as consistent with chronic rhinosinusitis. Okay, if you delved into her history a bit more, she's going to have another symptom, guaranteed, in addition to the pressure. Postnasal drip at some point. Now all of a sudden you've got two symptoms, CT findings positive, but you scope her and she's completely clear. And then you delve in a bit further and find out she's got clear migraines. And so this patient would very commonly, I hate to say it, but a lot of people out there will end up doing unnecessary sinus surgery in this situation. So again, got to be careful with ordering CT scans, and we'll go into that a little bit later about when to get one. And this just hits home this point that CTs need to be viewed with caution. 30 to 60% of people, which are all in those studies below there, have incidental findings on CT scans. That can be cysts. Radiologists might call them polyps, but they're not. Mucosal thickening, mucus. You can see this in patients with allergies or just a normal human being. And then CT findings do not correlate well with sinonasal symptoms. Right? And I like this study. I found it. It's from 1997. 220 patients, 60% had chronic, 35% acute rhinosinusitis. They looked at SNOT 20 scores. So back then they didn't have the other two. It was SNOT 20. They followed each of these patients with a sinus CT, which were graded by blinded radiologists. And here's a graph that you can just imprint in your memory. I think about this all the time when I'm thinking about CT scans. There's no correlation between the severity of their sinonasal quality of life and their CT scan. They even did a subgroup analysis of severe CT findings, more and more opacification, again didn't correlate. So the conclusions from this study, which are still hold up today, are that we reserve CT scans for the anatomy evaluation when we prepare for sinus surgery. It's really not helpful in diagnosing or grading the severity of disease. Okay, so I talked about all those components, symptoms, endoscopy, CT scan. Did you notice that the clinical exam was not in the criteria? Sort of blasphemous if you're in medical training, right? The clinical exam is part of your training. Well, it's just not that helpful for sinusitis. So when you look in the front of the nose or anterior rhinoscopy, sure, you can see inferior turbinate hypertrophy, maybe a septal deviation. If you have horrible polyps, maybe florid pus pouring out the nostril, but really most of the sinusitis we detect is further posteriorly, and you simply can't evaluate it without a scope. Here's one I think is pretty important. Palpating or percussing the face, which a lot of patients have had performed, or they read it online and start doing it to themselves, it's really not that predictive. I can't quote a study, but it's just if you push on somebody's face in the right spot, it does hurt. So that right there is reason just not to do it. Transillumination, this is an older technique. I'm not saying it can't work. It's just not been studied real well, and you would need special training to do it, so I don't think it's that helpful for you to know. Facial edema is almost unheard of in sinusitis. You have to have wildly erosive disease that goes through the bone to cause subcutaneous edema. So most of the time when patients think their sinusitis causes facial swelling, it's in the setting of maybe concurrent allergies, and actually some headache disorders can cause eyelid swelling. So it doesn't necessarily mean sinusitis. Now, I'm not saying you don't look at a patient, right? I mean, there are complications from sinusitis. So if it spreads to the eye, you might notice a proptotic or chemotic eye, or patients might complain of a stiff neck and light sensitivity. But otherwise, overall, the general clinical exam is not helpful. Okay, so that's how we pick up sinusitis. How do we manage it? Now, if you look over the last 15 years or so, we've got all kinds of guidelines for acute and chronic bacterial sinusitis. You would think by now we've really got a grasp on how to manage this condition. Should be crystal clear. Unfortunately, it's still not really. Okay, so what I'm going to do is just summarize this 2015 article that I sent out to you guys. I know you got it kind of last minute yesterday, but it is a good read. It's not too long. And here's the gist for adult sinusitis. Acute sinusitis, which again is less than 1 month or symptoms, when those symptoms have been present for 7 or more days, because until then, presumably it's a virus, most of the time anyways. So this guideline, interestingly, suggested Augmentin as a first-line option. Plenty of other studies have suggested plain amoxicillin, I realize, but found it interesting that they presented this, and for 5 to 10 days. Saline irrigations never hurt patients. Well, they can cause some ear pressure sometimes, but in general, very safe and help flush out mucus. And then there's the question of, okay, do you add a nasal steroid spray, Afrin spray, or Sudafed? I tend to reserve this for my patients that have prominent nasal obstruction during the acute episode. There is some older evidence that Afrin might decongest things and help with drainage. Not great studies on this, so it's an option. Chronic sinusitis, 3 months or more of symptoms. The standard here really is anti-inflammatory. That should be the focus. So oral prednisone taper, I prefer a 12-day taper, and then 300 milligrams cumulative dose. That's been shown in the ortho literature to be very, very unlikely to cause any hip osteonecrosis. And then here's the whole thing with antibiotics. It's an option still, based on surgeon or provider judgment, 10 to 14 days at a time. Sort of art of medicine, really. I personally don't prescribe them unless I see purulence draining from the sinuses. It's that simple to me. And I see very good results in temporary control with prednisone. But again, this is not a permanent fix for chronic sinusitis. You're just temporizing them until they decide whether they want surgery or not. And then the nasal steroid spray is a good maintenance therapy. I will admit it doesn't usually help a whole lot if they have severe disease, but you should at least consider that. And then the saline irrigation. Now, in both of these conditions, if they have concurrent allergies, you can always add on an antihistamine, but in general, we don't treat sinusitis with an antihistamine unless they have concurrent allergies. I figured we all prescribe antibiotics. We should at least go over the nauseating topic of antibiotic overuse. So it is an epidemic, frankly. Multiple guidelines from our literature suggest not prescribing them for uncomplicated acute rhinosinusitis because 90% or so resolve on their own. And there's really mixed evidence for chronic rhinosinusitis, hence why it's an option, but not a strong recommendation. It's the 5th leading cause of outpatient antibiotic prescriptions in the United States. This is a nice database-driven study I found from 2013. They looked at 2 national ambulatory care survey databases, 4 years. 82% of rhinosinusitis visits in primary care offices received antibiotics. If you look at this graph, acute and chronic rhinosinusitis accounted for more antibiotic prescriptions than any other diagnosis in primary care offices. It's pretty impressive. So what about Henry Ford? So, I gave this talk, I don't know, 6 months ago, got me thinking about what we're doing here. And so I've worked very closely with a couple different people now in the primary care realm. And we looked back at the last 2 years and looked at all of ENT and all of primary care providers, clearly more primary care providers. But you can see that ENT overall in the last 2 years prescribed 1,000 antibiotics versus 45,000 or so antibiotics from primary care. When we account for the number of sinusitis visits, about 25% of visits got antibiotics from ENTs. Nearly 80% got it from primary care providers. So it's following national data trends, which I found very interesting. So we're trying to think of ways to close this gap. And we've got an initiative going right now that I won't go into, but we're hoping to close that gap some over the next 2 years. And just to put my money where my mouth is, you can look at me here. Again, I reserve antibiotics for when I see pus draining from the sinuses. I scope every human that comes in with a sinus complaint, and I prescribe it in around 10% of my patients. And it's just, I'm not even anti-antibiotic. It's just, if I don't see pus, I don't treat with antibiotics. So from your guys' perspective, there's no perfect rule here, but I think just my anecdotal experience mixed with some literature is that if you hear yellow, green, or foul-smelling mucus, that's a little more consistent with an infection. You can be a little more selective. You don't have to give antibiotics to every patient with sinus complaints. Okay, so yes, it's good to know how to treat rhinosinusitis based on guidelines and such, but we have to keep a couple things in mind. Number one, you might not have the diagnosis right. It's actually very tricky to diagnose this properly without a scope. Okay, my predictive value would drop dramatically if I wasn't using a scope every day. And then you have to think, how many times am I going to treat this patient in front of me before I refer on to ENT? So that's what we're going to go on to here. So what do you guys think? How many courses of medical therapy for sinusitis should patients get per year before referring to ENT? There is no perfect answer. I just hope you didn't choose answer E, of course, but
We'll go over this a bit based on the literature.
Before we get into the literature, though, I just wanted to make sure you guys were aware of what we sort of do with sinus surgery. I'm not going to go over actual cases, but here's just an example of a preoperative left nasal cavity. That thing in the middle is the middle turbinate. You can see it's sort of sitting lateral. You can't see any sinus openings. So with sinus surgery, we're making big openings. We get that middle turbinate medialized against the nasal septum. We get the maxillary sinus, ethmoid, sphenoid wide open. This is flipping the scope to look superiorly at the frontal outflow tract. We basically maximize those dimensions to the defined bony boundaries so that we can deliver topical therapies better to all these areas. Now, with these openings in mind, let's talk about medical versus surgical therapy. There's tons of literature on this, but I like these studies that I'm going to show. That this one's out of Stanford, recurrent acute sinusitis patients, 220 patients over 8 years. This is defined as 4 or more episodes per year confirmed by objective criteria. They divided these patients into 3 cohorts. You got medical treatment, sinus surgery, or patients who got medical treatment decided to cross over to surgery during the study. So they all got 1 course of medical therapy at least, antibiotic, plus or minus steroid, plus or minus topical saline, plus or minus antihistamine if allergies. So good indications, good inclusion criteria. They compared SNOT-22, endoscopy, and CT scans between patients. They had no differences in demographics or pre-treatment disease burdens. Again, a nice clean study here. Overall, both sinus surgery and medical treatment achieved statistically significant SNOT-22 reductions. Remember, quality of life. But the sinus surgery group got greater SNOT-22 reductions at 3, 6, and 12 months of follow-up. And it's also important to know that 50% of that medical group crossed over to surgery. They just didn't quite get the symptomatic benefit they wanted, regardless of statistical significance. All right, so that's recurrent acute. Now for chronic rhinosinusitis, this is a multi-institutional prospective cohort study, 115 chronic sinusitis patients. They all failed a 3-week course of medical therapy, antibiotic, oral steroid, topical steroid. Same sort of study design, so medical group, surgical group, medical crossover group. All followed for at least a year and then looked at 2 different quality of life outcome measures. All the cohorts improved, similar to the other study. Surgical cohort got twice the symptomatic improvement at 12 months. And then a third of the medical cohort crossed over to surgery during this, again, due to inadequate symptomatic improvement. So where am I going with this? Well, it just suggests greater overall symptomatic improvement with sinus surgery when compared to medical therapy for chronic rhinosinusitis. And it's not necessary to give patients multiple courses of medical therapy if they're not achieving the symptomatic result they want. So where does this leave us with what you guys should do with referrals? So if we go by the literature, it would suggest that patients getting more than 3 to 4 courses of medical therapy a year, or chronic sinusitis patients getting more than 1 to 2 courses per year, in addition to having symptoms, of course, that bother them, those should be referred to ENT, or be considered for sinus surgery, I should say. But in reality, from the primary care physician's perspective, I would say after they've failed 1 to 2 courses, you can then consider an ENT referral, more just to confirm the diagnosis, make sure we're treating the right thing, and then that surgeon can talk to them about the risks and benefits of surgery. Now, I realize it can be a slippery slope in some places. I would hope that the ENT is being responsible and talking to them about the risks and benefits of surgery and focusing on getting the diagnosis and not just jumping to surgery. But again, in an ideal world, this is what could happen, and I think patients will get a greater symptomatic benefit with less medical therapy. Let's move on to unilateral sinus disease because it's unique and can be concerning. So what's the differential diagnosis for this? Well, for one, they all present non-specifically with the same symptoms as any other rhinosinusitis condition, but it's unilateral. So odontogenic sinusitis is ridiculously common. Acute or chronic rhinosinusitis. Quick plug for odontogenic sinusitis because I do research on this area. If patients say they have a prominent foul smell, especially in the setting of unilateral disease, think about odontogenic and just give us a call. Antracoinal polyps, benign or malignant neoplasms, different types of fungal sinusitis, benign fungal ball, by benign I mean non-invasive, I should say. Allergic fungal rhinosinusitis, which is really just a form of polyps. Invasive fungal sinusitis is the bad one that happens in immunocompromised patients, invades into tissue and outside the sinuses. And then encephaloceles or CSF leaks can present as a unilateral runny nose, right, or nasal obstruction. So unilateral disease, give us a call. Summary, ask patients what side bothers them. It's not always bilateral. Okay, we've covered true sinus disease. What is not sinusitis? So these are some issues that can seem quite sinusy. Non-sinogenic facial pain and pressure. I can't stress this how common it is. Migraine. Very common. Tension headache. Multiple other primary headache disorders that I don't know a whole lot about just by name. That's why I work very closely with our headache specialists. Allergic rhinitis. Obviously, 50% of our population pretty much has some degree of this, so very common. Then there's the cough or postnasal drip, quote, sensation patients. I put sensation because frequently the abnormality is not often the nasal drip, it's some degree of irritation of the throat. So way more likely in these situations, patients have laryngopharyngeal reflux with or without GERD, something called irritable larynx syndrome. It's also synonymous sometimes with a neurogenic cough. You can have a postnasal drip sensation or a weird feeling in their throat, a tickle, a pain, and a cough. Allergy and asthma together can make it seem like somebody has sinusitis. And then there's the upper airway cough syndrome, which I had to learn about by interacting more and more with primary care providers and allergists because we don't learn about this in our field. And in reality, I think it's more likely laryngopharyngeal reflux or irritable larynx or some of these other pharyngeal symptoms, and not so much a postnasal drip syndrome from the sinuses. We could talk for hours about that alone. I think one thing to keep in mind in all these cases, it sounds confusing because they can overlap, is this. I scope their nose. It looks pretty darn normal. There's no evidence of sinusitis. That's how I tease them out. So I do want to dedicate a little time now just to facial pressure and is it the sinuses? And yes, this emoji is kind of a manifestation of how I feel many days in my life. But I think it's important to tease out what is and is not sinusitis.
And facial pressure is one of the symptoms that can be very confusing, so we need to be proficient at teasing out whether it's from the sinuses.
Next question to everybody. If a patient presents with, quote, sinus headaches, what percentage are migraine? It's a lot of them. Wait, did somebody say 20?
40.
Oh, 40. All right. I like that too. But no, it's double that. So multiple studies have looked at this, but this is one of the landmark ones that gets cited in so many different papers. Prospective, multi-center, 3,000 patients with, quote, sinus headache in a primary care office. 80% met IHS criteria, migraine, 8% probable. So it's often reported as being 90% of these patients have migraine. I think that might be a little high, but we'll talk about that. 2007, a similar, smaller study, but prospective and observational, 100 sequential sinus headache patients, 86% migraine or probable migraine. My anecdotal experience, pretty darn close. At least I would call them non-sinogenic. I don't know that I don't think 90% of my patients have migraine headache, but a lot of them have tension headache, migraine, and then there's other interesting categories that I'll allow our headache specialist to talk about. But here's the kicker. 40 to 50% of these patients, and it was in the Schreiber study too, have autonomic symptoms like nasal obstruction, nasal drainage, eye drainage. So it can completely seem like you have sinusitis because you've got 2 or more symptoms with prominent pressure. You've got your symptomatic criteria. That's why it's important to scope patients. Okay, so when is it sinogenic pain and why is it confusing? Because it is. If you go by IHS criteria, even the most recent IHS criteria, International Headache Society, pain is attributed to rhinosinusitis when pain is associated with an active infection. And that means I scope somebody and see pus or edema. Though usually they'll have other sinonasal symptoms too. So it's not usually just pressure. They usually have the nasty mucus or something. Here's the other problem. Studies, including our guidelines, frequently report facial pressure or pain as one of the most common symptoms of rhinosinusitis. The problem is, if you delve into the references of those studies, they rarely report the concurrence of primary headache conditions. Patients can have both sinusitis and a primary headache disorder. It's been shown in multiple studies, but this was a study in 2013 in Laryngoscope, Lal et al., 211 chronic rhinosinusitis patients, 30% seen by a neurologist ended up having a positive primary headache disorder. So it's highly prevalent. And then, like I said before, these primary headache issues can have sinonasal or ophthalmologic symptoms. Multiple studies, I'm only citing 2 here, but 40 to 50% of these patients with migraine had some kind of ophthalmologic or sinonasal symptom. I mean, that's a lot. Okay. So you might think, okay, well, I can't tease it out based on symptoms alone necessarily, so let's get a CT scan, right? Imaging should show me. Well, that doesn't pan out either. So I'm just going to show a couple studies. There are a lot more than this, but here's a study, I believe out of Canada, 51 patients with rhinosinusitis. They looked at pain VAS scores and CT opacification scores. No correlation at all with CT burden and pain. This is a more recent study, really well done study, 83 chronic sinusitis patients, multi-center, prospective data collection. They did a really nice job asking every patient about the location of their pain, and they looked at their CT scores. What do you think? No correlation between location or severity. And so does this leave you feeling helpless? I don't know. Why get a CT scan? A lot of people get CT scans, ENTs included, and it can be very misleading. So that leads to the next question. Well, I can't trust the CT. Is there a hope? Well, of course there is. So I've been working really closely with our headache specialists, going through their literature, and there's this, it's actually geared toward primary care providers as a quick screen for migraine. This study, 2003, looked at 563 patients, 27 primary care sites, including 12 headache specialists. 3 simple questions were predictive, okay? You have a positive screen if you have 2 out of 3. Now, in the study, you had to meet pre-screening criteria, which basically was, do these really bother you? Did they have greater than 2 headaches in the last 3 months, and that they would ask doctors about? And then this screen came into play. All right, so using this, which was photophobia, nausea, and how disabled they were from it, 81% sensitivity, 93% positive predictive value. And there have been subsequent studies. The numbers, sensitivity, and predictive values have varied a little bit, but overall, highly sensitive and high positive predictive value, which is great because this is quick. And you will be blown away if you start asking every, quote, sinus pressure patient, do you have light sensitivity? Do you have nausea? You're going to get so many yeses that you never thought were possible. My residents are blown away all the time by it. All right. So let's summarize here. What can you do with patients that come in with sinus or facial pressure? I would say the IHS criteria are great to read about, but they're pretty cumbersome. You're also trying to think about sinusitis criteria, and you guys are dealing with every other organ system with patients. So it's a lot to process. I would say when you hear somebody say pain and pressure is their number one complaint or no other symptoms, think about the possibility of non-sinogenic facial pain. If you work at Ford, grab my smart phrase, .jc headache. Okay, there's hard stops through each of them. It's a thorough, it takes me about 5 minutes now to fire through it, but it does take a little time and there's a little bit of a learning curve. But it's great. It gets you organized and patients appreciate it too because these are confusing histories sometimes. Or you could just make a smart phrase for that 3-question migraine screen: nausea, photophobia, disability. If they screen positive for migraine or no other sinus symptoms, you can refer those patients to neurology. I've talked to neurology. If they don't have any suspicion for sinusitis, that's totally appropriate. But if you're unsure, just refer to us, okay? We'll scope the patients, figure out if they have migraine or not, and then I refer them on to neurology. All right, so that brings me into my last point about sinus disease.
Collaboration is absolutely essential when diagnosing what is and is not sinusitis.
Sinus patients often need more than one provider to diagnose and manage their condition because each provides valuable information. Now, we have to determine the contribution from allergic rhinitis, so that involves allergists. For cough patients, it's a kind of dynamic diagnostic process between pulmonologists, laryngologists, more so than rhinologists. I would say sinuses rarely cause cough, but we still get involved to rule out the sinuses. For that GERD or LPR patient with postnasal drip sensation, yes, they usually see me. I determine if they have sinusitis, and then I get them to see someone like a laryngologist who assesses the pharynx and the larynx, and then GI for the stomach and below. Facial pain and pressure. When it's isolated or prominent, I often involve headache specialists. They can have concurrent sinus disease, so it may take both of us. Okay, so these are all the different specialists involved in sinus care.
Okay, here are some conclusions on diagnosing and managing sinus disease.
How do we diagnose it? I'm going to call this a dynamic differential diagnosis based on most prominent symptoms. Get used to asking about these 5 cardinal sinusitis symptoms. Ask each patient to rank their symptoms. And this is like art of medicine. You don't have to do it this way, but I've found that if I get them to rank their symptoms or tell me what's bothering them the most, you can attack each symptom individually, and trust me, when you attack their number 1 symptom the best, they like you more. So elaborate on each symptom and its duration. Is it less than 1 or greater than 3 months? And I know it's cumbersome, but if you start doing it quickly and figuring out, okay, wait, they have anterior drainage, they have facial pressure, but the facial pressure is only there like once a year, and the anterior drainage is all. If you start paying more attention to that, you're going to see some interesting correlations. Okay. Thick drainage and obstruction, more likely sinusitis. Thin or clear drainage and facial pain, less likely sinusitis. Pain, again, is the least reliable symptom. If it's number 1 or isolated, it's most likely not sinusitis. Doesn't mean they can't have concurrent sinusitis, but a pretty good chance they have something non-sinogenic. Ask those migraine screening questions: photophobia, nausea, or type in .jc headache. Consider a headache specialist at that point. Manage expectations. I think one problem for patients is that they've been told for 15, 20 years sometimes it's their sinuses. They get 2 to 3 courses of antibiotics every year, and then for the last 12 months they've gotten 5 or 6. So then they think it's time to see an ENT specialist because their sinuses have gotten worse. Frequently, what's actually going on is more a headache condition that's progressed. And so again, maybe sinusitis, ENT will evaluate. Ultimately, rhinosinusitis is diagnosed by symptoms and endoscopy. CT can corroborate that. You don't have to get a CT. Incidental CT findings are common, and CT severity does not correlate well with symptoms, as we've shown. Remember this graph. We, as ENTs, tend to order CTs for surgical planning once we've decided they need surgery to look for different anatomic variants and plan surgery. Or, of course, if we're worried about orbital or intracranial complications and such. Unilateral sinus complaints, so ask patients, okay, I understand you have X, Y, and Z symptoms. Is it worse on one side? When it's predominantly one side, just give us a call, refer those patients, because we should check for something worse going on. Remember, immunocompromised patients, we're talking bad diabetics, bone marrow transplant, chemotherapy, cancer. More likely, we got to check for invasive fungal. Don't want to miss that. And then how do we treat it? So, you could get caught up in all the different studies that look at this antibiotic and that steroid and whatever. I just say choose an antibiotic and a steroid. Try 1 or 2 courses of that medical therapy. If patients aren't getting the symptomatic relief they want, consider referring. And based on your history, that may very well be ENT, but you can consider neurology, allergy as well. maybe combined referrals. For acute sinusitis, yes, that's usually an infectious process, so antibiotics are first line when they've had symptoms for 7 or more days. Topical saline, and then you have to decide art of medicine, do I give topical steroids and decongestants? For chronic sinusitis, anti-inflammatory is the mainstay, so oral steroid like prednisone, tapered over 12 days, it's sort of my regimen, a lot of places do that. Topical steroid, intranasal steroid, saline irrigation, and then plus or minus antibiotics. It is an option. You don't have to give it. There are plenty of people that consider it standard of care, but it's considered an option in guidelines. I highlight this again. You don't necessarily have to prescribe antibiotics. If you look at my antibiotic prescribing practices, I would say the majority of sinusitis is not infectious based on thousands of scopes. And then if you're lost and you're just not sure, find an ENT you trust, message us. Most of us like the sinuses. All right, take a mental breather. We're going to finish up with chronic rhinitis. You will never, probably again, get this much information on chronic rhinitis. All right, so rhinitis, I know most people know about, well, everyone knows about allergic rhinitis, and everybody might know the name non-allergic rhinitis, but I know I didn't know a whole lot about it prior to residency. And so if you look at some of these review papers, yes, there's a reason for that. Allergic rhinitis is more common, 3 to 1. But what's interesting is that 60% of allergic rhinitis patients have some degree of non-allergic triggers. So what are the different non-allergic categories? There's a number of them, and each of them has been studied very little overall, but vasomotor's probably gotten the most love in the literature. Then there's gustatory, which is a subtype of vasomotor. That's where when you eat something, basically you get a runny nose. Occupational, basically any chemical can elicit a reaction in someone's nose. We got rhinitis of pregnancy, which that's more so a congestion phenomenon, more so than the runny nose. Geriatric rhinitis is typically a watery runny nose. Infectious rhinitis, separate from sinusitis. There are forms of rhinitis, bacterial and viral, that can cause a runny nose. And then there's different drug-induced types. Okay, so if we're talking about the clinical presentation here, I'm just going to show the presentation for non-allergic rhinitis as a comparison to allergic, because I think most people are more familiar with allergic, so I'm just going to hit on non-allergic. Both tend to be bilateral presentations. The clear, thin rhinorrhea component is by far, in my practice, the most prominent symptom. Yes, they can have obstruction, but it's usually less prominent than allergic. Sneezing can happen too, but it's less prominent than allergic. And then the non-allergic patients are more constant or just random, no triggers they can figure out, or they have very specific triggers, okay, like the meals, wine, temperature change. It's not seasonal, so that can help you distinguish between allergic and non-allergic. And then lastly, they should have negative allergy testing, but then there's the kicker that some patients can have allergic and non-allergic. Okay, so yes, you have to know everything about non-allergic and allergic, and then know that there's overlap. Great. So what are some key questions and workup for these patients that come in with a runny, stuffy nose? For the runny nose component, we go back to what I kind of alluded to before. Is that drainage watery or thick and colored? Remember, thick and colored is more a sinusitis process, watery more a rhinitis. Are there associated allergy or sinusitis symptoms? Again, you just have to know an allergy history, the itchy eyes, itchy nose, seasonal variation, and then sinusitis symptoms, the 5 we mentioned before. All right, and then are there triggers? So I really try to get everyone to ask this every time a patient says they have a runny nose. What triggers are there? Okay, vasomotor, the classic ones are going to be meals with that subtype gustatory, alcohol, temperature, barometric pressure changes, different chemicals. There's a whole list of things. There's some suggestion that females are twice as likely, so there may be some hormonal effects that haven't been well studied. Different occupational exposures we mentioned. As far as drug-induced, it's like any other drug-induced problem. You got to take a good history and correlate it with when they take that drug. And then drug withdrawal is also a common cause. Okay, and then the one we don't want to forget about is CSF leak, right? So patient says, well, whenever I lean forward or I strain, I get clear fluid out my nose. It's a little concerning. All right, I say you always get allergy testing in these patients because I want to know how much of their condition is allergic. If they test totally negative, then I know it's not allergic. If they're allergic, then they might have mixed. Okay, and then hitting home this point of unilateral disease, right? So if you have unilateral clear drainage, lean that patient forward. It's called a passive teapot test. Doesn't matter if you know the name. Just lean them forward, see if they drip clear fluid out of one side. If they do, we should check that for beta-2 transferrin. If you don't know about that, just give us a call. So I'm just going to focus now on the treatment of vasomotor rhinitis. I hope everybody got that nice American Family Physician article, I think 2005. Does a great job at summarizing this. So vasomotor rhinitis is thought to be a condition of autonomic dysfunction. It's either hyperactive parasympathetic innervation, which is probably the more prominent theory, which then supplies the nasal mucosal glands. There might be a relative hypoactive sympathetic innervation too, but this is kind of a tough thing to study. All right, so no, you guys don't probably have to know this, but figure we might as well go over it, because when else will you hear about it? So the parasympathetic innervation of the nose comes from the facial nerve. So there's the greater superficial petrosal nerve and the vidian that supply fibers to the pterygopalatine ganglion. That then, so there's a synapse there, and then you get posterior nasal nerves that supply the nasal mucosa. So this is the right nasal cavity. Again, middle turbinate there on sort of the right side of the screen. And where I'm about to show you little nerve fibers is pretty posterior in the nose, near the back end of that middle turbinate. This will make relative sense when I show you some treatments in a bit. This supplies the majority of nasal secretion. And yes, there probably are more nerves that haven't really been studied well anteriorly in the nose, but this is what we've got for now. Okay, so how do you treat vasomotor rhinitis? So there are medical options, which mainly in the form of topical nasal delivery. This is going to decrease cholinergic-induced nasal secretion, so I think of that as a gland-level treatment. There are also surgical options where you can remove the parasympathetic tone to the nasal mucosa. This would be a nerve-level treatment where you're actually sectioning nerves distal or proximal to the pterygopalatine ganglion. Of course, what concerns you most is the medical treatment, and I can't stress this enough. When they complain of clear, watery drainage and they don't have clear allergies or they have negative allergy testing, Atrovent 0.06%. Don't waste your time with 0.03%. I have seen multiple patients not respond to 0.03. They do fine with 0.06 actually, and they can avoid a procedure. For prominent nasal obstruction or known concurrent allergic rhinitis, Flonase is obviously great, some type of nasal steroid spray. You'll notice that Astelin, an antihistaminergic spray, is second-line therapy for each of these situations, and that's true with allergic rhinitis in general as well. So what about when medical therapy fails? Are there surgical options? I don't even know that everyone knows there are surgical options. There might even be ENTs out there that don't know about the surgical options. So even in the last 3 years, a pretty significant breakthrough has been this intranasal cryoablation. Interestingly, I was the first to pick it up here in Michigan, but it's become a big deal nationally. We apply liquid nitrogen to the posterior nasal mucosa in that area where I showed you where the nerve fibers are. This causes submucosal, nonspecific posterior nasal nerve injury, so we're kind of ablating the parasympathetic fibers. That's shown there. You can also do this posterior nasal neurectomy, which is a selective sectioning of those posterior nasal nerves there. Or you could do a vidian neurectomy, which is proximal to that pterygopalatine ganglion. I realize you don't have to actually know these things, but it's just good to know that there are different degrees of surgical options for patients failing medical therapy. You might wonder how many people fail medical therapy. Atrovent spray works amazingly. Somewhere between 60 to 70% of people do perfectly fine with that spray alone. I think it's amazing. I think it's
a tragedy that it's not taught more regularly in medical school, at least where I went to medical school. In any case, some patients don't do so well with the spray, and so let's look at one of the surgical options here.
So this is a little video from my YouTube channel about intranasal cryoablation. This is in the office, topical lidocaine 4% applied to that area way in the back. We apply liquid nitrogen through this balloon device. It's about 1.4 centimeters in size, 30 seconds per freeze, and then you thaw it. And then you see there's the blanching area of mucosa, and that's caused submucosal nonspecific nerve injury. And it works pretty darn well. So what's our experience? Again, I told you I got to jump on this early, and non-industry sponsored, which has been, I think, important early in the treatment data that's out there. We did a multi-institutional retrospective case control study, 55 patients, 35 of them were from Henry Ford, and then these were only patients with non-allergic rhinitis and rhinorrhea. We looked at a number of different predictors, but the only one that came out significant was Atrovent response. So if people responded to Atrovent at all, partial or complete response, 80% success rate with cryotherapy. Non-responders, 20% success rate. And again, this is retrospective, but complications were low. So I look to Atrovent as kind of my guide to whether they're going to do okay with cryoablation. Of course, we need better studies in the future. Now, if they fail this, what do we do here? I've really liked this posterior nasal neurectomy. It's not written about much. I think I found a case series out there of 11 patients. I've only done 5 so far, but they've done excellent for the most part. One of my patients failed around 10 months, but he wants to redo it. I think the nerves may have grown through the graft. I'm not totally sure yet. So time will tell on this. And I think more and more institutions are going to start doing this. All right, pretty much done here. We're just going to conclude on rhinitis. So for allergic rhinitis, mainstay, of course, oral antihistamine, nasal steroid spray, saline irrigation. Second line is Astelin. At that point, you might want to consider an allergist anyways. For rhinorrhea related to non-allergic rhinitis, Atrovent 0.6%. I always write them as TID to start, but it's purely kind of PRN, really. If they're using it more than 3 times a day, they're probably not getting a great relief, but I tell them to titrate it to their needs. And then you have to consider their other symptoms. If they have prominent obstruction or allergies, you might need to add Flonase or an antihistamine spray. If that fails, refer them to ENT or specifically a rhinologist. Some ENTs do the cryotherapy actually now. We don't have high quality studies per se, but maybe Atrovent response is a great predictor of whether they're going to do well. You can retreat those patients if they fail, or you can consider the neurectomies. There's posterior nasal neurectomy as well as Vidian neurectomy, but we just need more studies on these more aggressive approaches. Most people do so well with medical therapy that you don't get to this stage. So there's my talk. Thank you very much. I'd like to just throw a plug in here for my YouTube channel. Most of it won't really pertain to your training, but sometimes patients want to know about sinus surgery. A ton of videos on there. They're all narrated. And then I leave you with one last thought, which I may have said a few times. Facial pressure is the least reliable symptom of sinusitis.